Hi, and welcome to Pharmacology for the Dental Hygienist, lesson number 1, Introduction and Overview. Let me introduce myself. I'm Julie Breen, also known as the Toothy Tutor, and I'm here to help you discover, love, embrace the dental hygiene journey and all the learning that you will do over the next 2 years. So this is one of the more difficult courses. So I will be releasing a video or two every week going over the entire curriculum of pharmacology in the dental hygiene program. So let's start at the beginning with what is pharmacology. So pharmacology is derived from two Greek words, pharmaco meaning drugs or medicine, and ology meaning the study of. Let's go a little deeper. So what are drugs? So drugs are chemical substances, and pharmacology is a lot of chemistry. It's probably why you had to do some prereqs in Chem 1, Chem 2 before taking this course. So there's a lot of chemistry. We're going to do a deeper dive into chemistry in the pharmacology lesson number 2. But for right now, know that drugs are chemical substances or chemicals that are used in both animals and humans in the diagnosis, treatment, and prevention of disease or other abnormal conditions. There are multiple different pharmacology divisions. Probably the two that you need to be most familiar with is pharmacokinetics and pharmacodynamics. So let's look at those a little deeper and try to figure out how they're a little bit different. So pharmacokinetics is the study of what the body does to the drug as it moves through. From the time you ingest, inhale, inject the drug until you excrete it, what the body is doing to that drug. So pharmacokinetics, what does the body do to the drug? It's known by the mnemonic ADME, absorption, distribution, metabolism, and excretion. Pharmacodynamics is a little bit different. It's the mechanism of drug actions in living tissues. What does that mean? What does the drug do to our body? Does it relieve pain? Does it reduce our blood pressure? Does it reduce fever? Does it prevent seizures? So that's what the drug is doing to our body, and that is pharmacodynamics. We can get drugs from multiple different sources. Plants, so the poppy plant is where opium is derived and where heroin is formed, I guess, or created from the poppy plant itself. So that is actually plant derived. Things that are minerals would be something like Rolaids, things that you take for a stomach upset, which is usually made of magnesium, so that's a mineral. Animals, we used to get insulin from bovine, which is cow, or porcine, which is pig. So we used to actually have to slaughter animals to get insulin from them. But now insulin is created synthetically in the lab, and the majority of the medications that we take now are synthetically created within a lab. So what is our role as the hygienist in learning and knowing what your patients are taking? So it's helpful when we're doing a medication and health history, what they're taking, what are some of the side effects like xerostomia, might they faint if you sit them up too fast, medication administration, you give drugs, you will deliver local anesthesia, topical anesthesia, Arrestin. You need to know what side effects can come from the drugs that you administer and what can happen if you combine certain drugs together, ones that the patient is taking and ones that you are delivering. Things that you can deliver in an emergency situation. Someone comes in and they're having an opioid overdose, how to deliver Narcan intranasally. Different things in the medical kit that you need to know what would be indicated based on patient's symptoms if they're having an emergency in your chair. Appointment scheduling. Some patients, dependent on their condition, dependent on some of the drugs that they take, you may want to schedule them right after lunch. You may want to schedule them first thing in the morning. And then lastly, non-prescription medication and nutrition supplements that patients may be taking, but they may not consider, oh, this has nothing to do with anything. I just bought this at the CVS. So the non-prescription medications that could impact our care or what is happening with the patient is if they are taking a baby aspirin or a full dose aspirin every day, they may bleed a little bit longer. If they're taking something like St. John's wort or other nutritional supplements, they may have side effects when you combine them with the epinephrine or the vasoconstrictor within a local anesthesia cartridge. So these are all reasons why, as professionals, we need to know what the patients are taking and what they do and possible side effects or possible contraindications for combining them with drugs that we administer. Lots and lots and lots of drug information, sources of information. A lot of people go on the internet and look them up. That's a great resource. Another great resource, Mosby's Dental Drug Reference, because it actually gives you specific dental considerations for every drug that a patient is taking, whether they'll bleed more, whether they'll have gingival hyperplasia, whether they'll have xerostomia. So these are all things that are important for us to know, and it's right there in a handy reference book. So how are drugs named? So there are 3 different ways drugs are named. Initially, when the drug is being studied and created by a company, it is known by its chemical name, and that is determined by the chemical structure itself of the compound. Sometimes the chemical name is also used interchangeably with something called the code name. Then there is also a trade name. You can usually identify a trade name because it is capitalized. So here we see Motrin with a capital M and Advil with a capital A. And the trade name is used for marketing purposes. And then lastly, the generic name, usually a lowercase, and we can see here the lowercase is I, so ibuprofen. So the generic name is the official name of the drug. And for each drug, there is only one generic name. So ibuprofen is the only generic name. However, it is marketed by different companies under trade names such as Motrin or Advil. And here's another example. This is all the same drug. We have the chemical name, which is the big long name. And then we have the lowercase diazepam. And Pam, if you look here, a little clue for you, if a drug ends in PAM or LAM, Pam, LAM, you can almost guarantee that that drug is a benzodiazepine. So we can see here diazepam, benzodiazepine. It's also marketed under the trade names Valium and Diastat. So as drugs are being created by different companies, it goes through a whole bunch of clinical studies. So the first thing that they want to look at, is it safe, right? Is it killing people, right? So is it safe? Does this drug not cause life-ending side effects? So we want safety in a small group of people. The next phase is they want to test to see the drug's efficacy. Another word for efficacy is effectiveness. Does the drug do what it's supposed to do? Because is a drug really great? Oh, sure, it's perfectly safe, but it doesn't do anything. It doesn't fix the problem or the condition that they're trying to fix. So if a drug is a high blood pressure medication and it doesn't lower the blood pressure, it's really not effective. So it would be stopped at phase 2. So the first we do safety, making sure it's not killing people. Second phase is it effective? Does it do what it's supposed to do? Then phase 3, it starts to see what is the dosage needed to make sure and that it still is safe at that dosage and it is effective at that dosage, and it goes to a larger group of people at that point. And then phase 4 is post-marketing surveillance. So now the drug has been released to the public, people are taking it, but they're still looking to see if something called a signal happens. So a signal is when all of a sudden you see in this small cohort of people, I'll take myself for an example, a middle-aged postmenopausal woman, all of a sudden cardiac arrests are happening with this drug. So that's a signal, uh-oh, what's going on here? Is there something with the age? Is there something with the gender? Is there something going on in just this small cohort of people? So that's when drugs sometimes are pulled off the market. Sometimes they are placed back on the market, even if there's a signal, even if it has ended someone's life or a group of people's lives, they'll still think that the drug for some of the population is worth it. And then that drug will get something called a black box warning. And the black box warning indicates that there are life-threatening side effects associated with this drug. So in the United States, drugs are regulated by a whole host of different federal agencies. We're going to focus mostly on two, which is the FDA and the DEA. So the FDA is the Food and Drug Administration, and that they look at, is the drug safe and effective? Does this drug need to be a prescription? And they're always looking at those things because even recently, probably within the last 15 years, you used to have to go to a physician and get a prescription for something like Monistat, which is a vaginal yeast infection medication, but the FDA determined it did not need to have a prescription, so now it is over the counter. The other thing the FDA does is drugs are made all over the world, so they send inspectors to the facilities that are making the drugs that come to the United States to make sure that those facilities are meeting specific quality control standards, if they're clean and safe. The FTC, so the FTC is another federal regulation, and that is that you can't have a label on a drug that says something sort of ridiculous like, oh, it's going to make you look 50 years younger. So it bans misleading advertising on specific things, foods, drugs, cosmetics. OBRA is a law that requires pharmacists to offer counseling to patients who are Medicaid patients, but many, if not all, state boards of pharmacy require that if you've received a prescription recently, they'll say, do you have any questions for the pharmacist? You say, no, sign here. So that's actually what OBRA, the Omnibus Budget Reconciliation Act, is. You have the opportunity to ask the pharmacist any questions regarding the drug that you have been prescribed. So drug regulation in the United States, we have the Harrison Narcotic Act, 1914. So prior to 1914, things like opium, opiates, and cocaine were sold over the counter, meaning you could just pick them up at your neighborhood pharmacy and take them for a variety of ailments. If you had bad nerves or you wanted to sleep better, or you could go and get these drugs right in the pharmacy without even asking a doctor for them. In 1937, marijuana laws were added. So an example of a drug that people used to give their children was something called Mrs. Winslow's soothing syrup. And so this was the mother's friend for children who were teething. So this had a combination of something that was heroin-like and also cocaine, because that's a powerful anesthetic, that mothers would rub onto their children's sore gums. And you can imagine that's probably not a great thing to introduce to an infant. So that the Harrison Narcotic Act of 1914 sort of made it was not legal anymore to just go into the pharmacy and pick up Mrs. Winslow's soothing syrup. Now we also have the DEA, the Drug Enforcement Agency, which is part of our Department of Justice, and it regulates the manufacture and distribution of substances that have the potential for abuse. So prescribers that prescribe drugs who have a potential for abuse, things like our opioids, are assigned a DEA number. And the DEA really monitors who's writing prescriptions. Like a pedodontist should not be writing a lot of prescription for opioids, versus an oral surgeon might write a lot of prescriptions for opioids after a third molar extraction or an implant surgery. So it's really sort of specialty specific how many a prescriber can prescribe before, like the DEA. I don't know personally how they do it, but I'm wondering if they have some sort of like alert system if someone significantly goes over the number that they feel that they should be prescribing. The DEA also enforces the Controlled Substances Act. And the Controlled Substances Act is an act that puts drugs who have a potential for abuse in different schedules. So the lower the schedule, the higher the abuse potential. Schedule 1 has the highest abuse potential. Something in there would be heroin, PCP, currently still marijuana, but that might be marijuana may be moved to a Schedule 3. So Schedule 1 is highest abuse potential. Additionally, there are no medical indications for this drug. So you might think cocaine is a Schedule 1, but cocaine is a powerful anesthetic and it is still used topically, meaning through tissues, for scoping of the nose. Sometimes they'll spray a cocaine-based drug into the nose to numb it. So cocaine, high abuse potential, but there is a medical indication for it, so it is a Schedule 2. Recently, hydrocodone and Vicodin were moved from a Schedule 3 into a Schedule 2 because they were finding people became dependent on opioids even with Vicodin prescriptions. Schedule 3, Tylenol 3, which is Tylenol with codeine. Schedule 4, diazepam, which is a benzodiazepine, also has a potential for abuse. Xanax, so these are our benzodiazepines, our anti-anxiety medications, also known as our anxiolytics. And then Schedule 5, codeine is a powerful antitussive, and to tuss, T-U-S, think of Robitussin, which is a cough medication. Tussive means to cough. So codeine is a powerful antitussive. The other thing that these drugs, opioid-like drugs, things like Vicodin, oxycodone, hydrocodone, these all are very, very constipating. So if someone has significant diarrhea, they may prescribe them something called low motil. So diarrhea is fast motion, fast peristalsis, where if you look at the drug name, low motil, low motion, it slows those waves so you don't have diarrhea anymore. And it is very helpful for that. So there's a lot of requirements for prescribing scheduled drugs on the schedule, things like Vicodin, things like benzodiazepine. You have to have your DEA number included, and Schedule 2 through 4 require a prescription. Schedule 2, things like our Adderalls, like amphetamines, must be typed or written in pen or indelible ink, cannot be telephoned in, require a new prescription for every refill. And then Schedule 3 through 4 may be phoned to pharmacy, but may not be refilled more than 5 times in a 6-month period. Now in Massachusetts, where I'm from, all of these written things have sort of been removed because we have something called the Massachusetts Prescription Awareness Tool, or MassPat. And you need to use MassPat whenever you prescribe an opioid. And the research does show it's lowering the number of opioid prescriptions. It is just also, you need to go into MassPat. You need to use that tool now whenever a patient is also prescribed a benzodiazepine, diazepam, Ativan, anything like that, any kind of benzo. So the Massachusetts is battling the opioid epidemic on multiple fronts. Prescribers have a critical role to play, and I've pulled this right off the Massachusetts website. So using this tool, it allows you to view a patient's history, kind of their total history, so that they're not going to their orthopedic surgeon and asking for an opioid, and their general practitioner, and their dentist, and their foot doctor. You can see every opioid that they've been prescribed, so they can't go to multiple practitioners. And this enables an early alert system to identify potential misuse or abuse and early intervention if a patient is potentially abusing. So, prescription writing. So, what is a prescription? A prescription is a healthcare provider who writes certain instructions or prescribing orders to a pharmacist to dispense a specific drug to a patient. And right now, the metric system is what we use, and things like milligrams, like you take 2 milligrams of amoxicillin prior to dental treatment. The apothecary system is a previous system, and the apothecary system is things like drams and grains. You almost never hear that anymore. On the bottle itself, though, you won't get the metric system. The prescriber, the pharmacist will write on the bottle. So if you had to take 2 grams of amoxicillin prior to dental treatment, the pharmacist will dispense 4 500 milligram tablets. And so what the pharmacist will put on the bottle is take 4 tabs. So the patient is getting their 2 grams, and that way the patient doesn't understand a lot of times the milligrams or milliliters. Like if you said to someone, oh, take 5 milliliters of this liquid amoxicillin, they don't understand that the way if you said, take 1 teaspoon, which is the same. So a teaspoon and tabs and things like that is called the household system. So, I kind of talked about this already. Okay, primary system used in pharmacy, solid drugs in milligrams. So think about grams as solid drugs, and liquid drugs are by volume or milliliters. And I always think of liquid as when I go and I get, oh, grab me a 2-liter bottle of Coke. So 2-liter has kind of become adopted as like, I think about liter as being liquid. And that's how I sort of remember that. And then household measures, sometimes you get the little dosing cups, or you get, like for my animals, I get like a little syringe, a pre-filled syringe. That's great. So here's what an old written prescription would look like. It would be a heading, which is the top, a body, which is the middle, and then a closing, which is the end. DEA number would have to be included if the prescriber, the doctor, is prescribing a drug that is in the controlled substances, Adderall, Vicodin, anything like that. All right, so the next thing we're going to look at is drug action and how the body handles drugs. So terminology, onset of action. That's the time between I took my ibuprofen, I put it in my mouth, and my headache's gone. So time you take it, administration, when does the therapeutic effect begin? Site of action, that's where the drug exerts its effect. I have high blood pressure, I take a drug that works in my kidneys. Because blood pressure, a lot of times it's either 2 problems. You have too much water or your vessels aren't big enough. So high blood pressure medication is going to work to help you get rid of water through urination or to open up your pipes or your vessels through vasodilation. So site of action of a diuretic would be in the kidney. Site. Mechanism, how the drug works in the body. Diuretic, how does that drug work? It keeps sodium in your kidney. Water is attracted to it, and so it ends up going to the bladder and you urinate it out because the water always stays attached to the sodium within the kidney, down through your ureters, the bladder, the urethra, into the toilet. Dose, how much do you need? So the dose, how much? So For a headache, for ibuprofen, it's usually, those are 200 milligram tablets. You usually take 1 or 2. So I would say the dose is probably 200 milligrams. Well, if I gave you ibuprofen in 1 milligram, that's not going to be an effective dose. Duration of action. The length of time the drug produces a therapeutic effect. And this helps us, the duration of action of a drug helps us with dosing intervals. So some drugs, if you have strep throat, you need to take it twice a day, or maybe you need to take it once a day, and maybe you need to take it 3 times a day. And that's all dependent on how long the drug is active in our body. So routes. For a drug to work, it has to come from the outside and get inside us somehow. Lots of ways. Go through our mouth, go through our butt. We can inject it through into a blood vessel. We can inhale it into our lungs. We can do it topically through our skin, under our tongue. So the route of administration affects the rate of onset, the rate of absorption, and the duration of action. So the rate of onset, how quickly it works. So something is going to work much faster if you inject it directly into a blood vessel versus if you take something rectally. Rate of absorption, if we talk about absorption, we're talking about into the systemic circulation. So when you inject something directly into the systemic circulation through IV, much faster rate of absorption, obviously, because it's a direct line. And the duration of action. Something that goes directly into your veins versus being ingested through the GI tract, either orally or rectally, will last longer because there are more active or bioavailable molecules to act on receptors in our body. So there's also something called the enteral and parenteral route of administration. And enteral means the delivery of a drug via the GI tract. So that's mouth and butt, right? We're one long tube from our mouth to our butt. And then parenteral, all other means of delivery, but usually sometimes it's used interchangeably as an injection. So enteral routes, I give you a little Latin here, PO, which means by mouth. So advantages. Well, it's pretty safe and convenient, and it's not very expensive. Disadvantages are some drugs cannot be delivered by mouth because the stomach acids and enzymes will destroy them. That's why people have to inject insulin. They can't swallow insulin because it will get destroyed by the stomach acids. Slower onset, anything going through the mouth has to go through the liver before it gets to our bloodstream as a protective mechanism. So when you swallow something, if you swallow a drug, it goes through the liver first. And that first pass through the liver is called the first pass effect. So the first pass effect is the metabolism of a drug. So metabolism of a drug means its breakdown. It's broken down into its non-functional units. Metabolism is prepping these molecules to be ready for the body to excrete them or get rid of them. So the metabolism of a drug and its passage from the liver into our systemic circulation, meaning our bloodstream. So if you give a drug orally through the mouth, some drugs can be extensively metabolized by the liver before ever reaching the systemic circulation, meaning they have a high first pass effect. So you take a drug that has a high first pass effect, you'll have almost no working molecules getting spit out of the liver into the systemic circulation. So if you give the same drug by IV, it will bypass the liver first. Eventually, we're a closed system. Our blood circulation is a closed system. It will eventually get to the liver where metabolism will take place, but it will skip it first so that there will be some working molecules to produce an effect. Look at this little image. I love this. Here's the drug and you take it. Here's your stomach. It's getting into the GI tract. but before it enters our systemic circulation, it gets sucked into the hepatic portal system. It goes through our liver. These are safety things. Let's not just spit out poisons into our bloodstream, right? Let's get sucked into the liver, sniffing it. It's good, it's good. Okay, now we can get into the regular systemic circulation. But again, sometimes it can metabolize certain drugs way too fast, and you get almost no working molecules out the other end. So those types of drugs need to be administered by IV first. All right, another enteral route. So we had PO by mouth, PR per rectum by your butt, right? Advantages if you are uncontrollably vomiting, and infants, children, and elderly. Disadvantages. Patients hate having this done, right? And the amount of drug delivered is unpredictable. The amount that actually reaches the systemic circulation is very unpredictable. So this is not a great way to deliver medications. So parenteral routes. So these are the injection ones: intravenous, intramuscular, subcutaneous. So intravenous, right into the vein. Some good things about it: there's no high first pass effect, it's rapid, it's predictable. Bad thing: patient has an allergic response. If it's been delivered into a vein, there is no way to get it back. If someone has swallowed a drug that they have a response to, an allergic response to, you can make them vomit it up. So allergic reactions are always a risk with IV. Intramuscular, a way to think about that is our hepatitis B vaccine. Good absorption intramuscularly. Now, we used to get intramuscular in our bum, but over time, as people have gained weight and the population has become heavier, the muscle of the bum has been covered with a layer of fat. So now they give it into the arm, and oh, that is sore after when it goes into the arm. It's really, especially as a hygienist, I make sure I got it on my left because I needed my right hand to work. And then subcutaneous. This you need to know. So subcutaneous is the delivery method of our local anesthetics. We deliver those sub-Q, it's called. So make a note of that, very important. This shows you kind of the depth and the angle that you need for intramuscular, going deep, intravenous a little less deep, right into the vein, and then subcutaneous going right under the skin. There's also intradermal, which is the skin between the epithelium and the underlying connective tissue. And that's our tuberculin test that you would have right here on your forearm. Remember getting that done. And then intrathecally is the space in the spinal column, that's spinal anesthesia. So then we have topical. So our skin, we can think of things like nicotine patches, or for terminally ill patients, patches with fentanyl in them, very powerful opiate. Mucosal through our thin tissues, and the uptake of this approaches IV. It's why angina patients, someone who is having chest pain, will take their nitroglycerin sublingually underneath the tongue. Those tissues are so thin. And then subgingivally is things like Arrestin and Orachix. And lastly, yay, inhalation. So that is through the lungs, inhalation through the lungs, and the onset is very quick. The drug enters the blood very quickly, and that's things like bronchodilators, nitrous oxide, and some volatile anesthetics in general anesthesia. All right, so if you found this helpful, please give me a follow, send me a message. I love to hear comments, questions, and follow me or go to my Stan store and look at some free links that I have of case studies. And I look forward to seeing you for lesson number 2.